Welcome to Health and Living with me, Dr.J. Today we're with Dr. Moyo on OBGYN, and we're going to be discussing infertility in women. Welcome, doctor.
Thank you. Welcome.
Before we go further, can you tell us what an OBGYN is for someone who doesn't know?
Well, OBGYN is a part of medicine that deals mainly with reproductive health and in mainly women. The OBG is the obstetric component that usually deals with the delivery of babies and pregnancies before and after the pregnancy, the care before, during and after the pregnancy. And then the gynae bit is the one which deals with the genital tract, like the womb, the ovaries, the tubes, and their general health in terms of infections, cancers and things like that.
Okay. So today, since our topic is infertility in women, what is infertility?
Well, in general, infertility is defined as failure to conceive after a period of 12 months of regular, unprotected intercourse in a woman who is not taking any contraception. But the definition changes if the woman is more than 35 to say we start investigating them much earlier than at 12 months, in 6 months, because of the age problems. But in general, it's a failure to conceive in a period of 12 months.
Okay, and what is our incidence here in our local setting? What's our incidence of infertility in women?
Well, the studies that have been done with the ZDH have shown that the incidence is between 10 and 15%. Okay. But it's really underreported, because most people who have got this kind of problem, they don't come out in the open, and some of them actually don't come to healthcare institutions. They go to prophets, nyangas and things like that.
Okay.
So the incidence might actually be higher, and especially in our society where the risk of having, where the prevalence of sexual transmitted infections which damage the tubes and cause subfertility is much, much higher. Earlier on in the 80s, studies done in Gweru showed that the prevalence of STIs was as high as 49% in our population. So the 10 to 15% is really an underestimate.
Okay. And what factors do you attribute our infertility to?
Okay. Infertility is generally attributed to either male factor, female factor, or both, or what we call unexplained. Basically, in about 40% of the cases is female factor, and another 40% is male factor, and then 10% is both male and female, and then another 10% you can't tell what's going on. All the investigations will be normal on both sides, which is what we call unexplained. These figures, they vary with settings, type of studies and investigations done. In female factor, basically you're looking at conditions that affect production of the oocyte, the egg. Okay. As you know, a woman every month must go for a period, a regular period, and this is like a rough test to say they're actually ovulating. So around mid-cycle of the period of the cycle, a woman must release an egg, and that's the egg that is fertilized by the sperm. So you get conditions whereby the woman is not releasing that egg, what we call anovulatory cycles, or conditions that are causing anovulatory cycles. There are quite a number of them. And then the next group of conditions in women are conditions related to tubes. When an oocyte or an egg is released by a woman in the mid-cycle, it has to be picked by a tube, and then fertilization takes place in a tube. So if you have conditions that damage the tube, causing the tube to block, and mainly things like infections, pelvic inflammatory disease caused by chlamydia and gonococcus, they block the tube, and therefore the woman will still produce the egg, but the egg cannot be picked to meet the sperm. So the group of conditions that cause problems with the tubes. Then you do get conditions that affect the womb itself, things like fibroids, endometriosis, a whole lot of other conditions that will affect the womb, make the womb unreceptive, that means interfere with implantation, or destroy the womb's architecture, making it difficult for them to either implant, or destroy the ovaries, making the ovaries have depleted oocytes. So that's on the female side. And then on the male side, you're mainly looking at production of sperm. You get conditions whereby there's primary defect in actual production of the sperm itself, leading to either no sperm or little sperm. When there's no sperm, we call it azoospermia. When there's little sperm, we call it oligospermia. Then you get specific conditions which affect the transportation. When the sperm is produced, it has to go through tubes and, until it's finally released. So you can get conditions that actually affect those tubes and cause obstruction. So when the man has intercourse with the wife or female partner, they release the fluid, but the fluid will not be containing sperm. Then you get other conditions where the sperm itself is affected one way or the other in terms of the appearance, function, like a whole lot of conditions. And then you have other conditions where the sperm, instead of coming out with the ejaculate, doesn't come out with ejaculate and goes backwards. That's called retrograde ejaculate. And you have men with problems with actually maintaining or getting an erection, right? So those will have problems delivering sperm to the vagina. And then you have medical conditions affecting both male and female that are not in the genital tract. For example, someone who's diabetic, someone who's got a thyroid disease, someone who's got any other hormonal disease, which will sort of affect either the production of the egg or the production of the sperm as a secondary effect, being a condition that is way outside the main genital structure.
Okay.
Yeah.
So I'm sure as an African doctor practicing OBGYN in Africa, you hear people say things about maybe supernatural causes. Nothing to do with medicine, nothing to do with all that. People who come and say, someone in my family did something, I think this is why I'm in this situation. What do you think of those things?
Most of the time, actually, it's not true. Because except in the 10% which I said you can explain, most of the time you can actually find a cause. If you get an opportunity to see that person and go through the investigations and examination, you will find a cause. People a long time ago had a way of explaining things which are scientific, and they've got a scientific diagnosis, but they'll explain them in their own way for themselves to understand. There are a lot of people who say, there are lesions there and they're killing babies, or, the womb is dirty, it needs to be cleaned. When we do examine, and we actually find a problem, and we can actually treat it. So I don't believe that there are supernatural causes. Of course, if one is stressed, has gone through a lot of trauma, they can go into a state where they're not producing an egg, become anovulatory.
Okay.
But that's scientific, that they're not ovulating because of the stress.
Okay. So if a couple is at home and they feel like they've tried everything, no baby, at which point should they then come? When would you suggest someone comes? What should be happening between the husband and the wife, where they should say, you know what, let's go and get checked?
Like I said in the beginning, if it's a young couple, and the female partner is less than 35 years, certainly after a year, 80% of couples would have conceived. After that period, then there's a reason for them to visit a practitioner to have themselves checked. But if the female partner is more than 35 years, after trying for six months, there's a need for them to go and be checked, because female age is the most important factor in terms of outcome for treatment and and everything else that happens in fertility. So if you are 35 and you have not conceived for 6 months, the idea is that you present yourself early so that whatever it is that is wrong can be sorted out much early than leave it when you're now 36 and 37, and then the chances of being able to be sorted out are much, much less.
Okay. So can you walk us through the typical infertility workup, especially from the women's side? What can someone expect when they show up to the doctor for an infertility workup?
Okay, there will be a detailed history and that will be taken, and that history will mainly involve their reproductive history, including things like when they became, when they started seeing a period with the monarch, and their sexual development, and that's secondary sexual development, things like breasts, pubic hair, and then obviously a detailed history about the period, the cycle. Is it a regular cycle? Is it a heavy cycle? Is there a pain during the cycle? And then obviously more information will be sought in terms of their past medical history, if they suffered from any infection before. As I said, the infection in pelvic inflammatory disease can tend to destroy the tubes. And then that will be followed up by maybe a social history to find out if they smoke or drink. And then an examination will follow, which will look at things like the weight and the height to calculate the body mass index, and then other examination of other systems to exclude other medical conditions which I mentioned to you, which would interfere with the ovulation and things like that. And then obviously a detailed examination of the genital tract to exclude things like fibroids and ovarian cysts and things like that. This will then will be followed by a scan, and usually as fertility doctors we do what we call a transvaginal scan that will then look at the womb in detail, to look at the lining, which is endometrial lining, and then also look at the womb itself to see if there's any fibroid and adenomyosis, and then also look at the eggs in detail, the ovary, and sort of count the legal eggs that are available to find out what the reserve for that woman is, and then also look at other things around the structures there to see if there's anything that can actually interfere with their fertility. And then in terms of other investigations, there are blood tests that are done, and these are mainly hormones to exclude hormonal imbalance, and then also hormones to check for the reserve. And we also do tests to check for ovulation. This will come in the form of kits, the kits that one can do like mid-cycle using urine, which measure a hormone called LH, which will appear as a double line if you have ovulated and things like that. And then also mid-luteal or day 21 progesterone level will be ordered to check if one has ovulated. If a suspicion is there that the woman has got tubal problems, mainly there are two tests that can be done, 2 or 3 tests that can be done. One involves going to theater and doing keyhole surgery, what we call a laparoscopy and dye study. This is whereby we use a small telescope and then we put a dye while someone is under anesthetic, and then see if the dye spills on both sides of the tubes. If that's not possible, we do use x-rays, what we call it an HSG. This one is done in an x-ray department. No need to go to theater. A dye is put from below, and then x-rays are taken to see if the dye spills. We can do the same test using a scan, whereby we inject a radiopaque material from below, from the vagina and through the cervix, and then do scans to see if the dye spills. So those are the main tests, and obviously other tests, like I said, medical conditions to exclude diabetes and things like that. But those are the main things that will be done to a woman who's coming for first time for some fertility issues.
Okay, so having found the fertility issues then,
Yes.
what are our solutions, especially in a local setting? But generally, what are the solutions, but then focusing on in our local setting?
Well, our local setting, we actually now offer a full range of treatment.
Okay.
We used to say there's a limitation to what we can offer. We have no limitation. We have no such limitation. So it depends on what the problem is. If it's an ovulatory problem, we do give ovulation induction agents, and these are oral drugs which can be given. We'll be given instructions when to take them and then when to have intercourse. If it's a problem to do with tubes, obviously the two options, whether you can open the tubes or go straight to IVF, and this will depend on the clinical judgment on what is going on. Sometimes you get women who have got pattern tubes who have got ovulatory problems, and just simple ovulation induction and timed intercourse does not help. So those can actually be, if the male partner, the sperm is okay, they can be move on to what we call intrauterine insemination of the sperm. This basically is a artificial reproductive technique whereby the woman is stimulated mildly to produce just a few eggs, and then the sperm is collected when those eggs are now considered to be okay or ovulated, and then the sperm is prepared in the lab and then is put in the uterus through a small tube. That's intrauterine insemination.
Okay.
Yeah. For those cases where all these other methods are not effective or have failed, or the tubes are damaged and you don't think you can open them, or the male factor is so bad, then we can offer IVF.
Okay.
Yes.
So you're the only doctor in Hawaii who offers IVF?
For now, yes.
Yes. Can you tell us a little more about it and why you felt the need to offer a service like that?
Well, let me answer the second question first. For a long time now, IVF was not available in Zimbabwe. In the 90s, it was available in Harare. And then around 94, some late 90s, the clinic in Harare closed. And it reopened again in 2015, thereabout. But for a long time when I was practicing, the services were not available. Our patients were going to South Africa and India. IVF treatment is a long treatment. It takes about 21 days to a month for the whole cycle to be complete. So it's a problem for someone to leave Bulawayo, leave work, leave family, and stay in a hotel or a lodge if they don't have a family in South Africa or in India. It becomes expensive. It takes them away from their short social support. You know, if you're going to a clinic and your sister or your mother or your brother or your friend is going with you, it's much, much easier than if you are in a hotel and you're just going to see strangers and they're helping you, they're trying to help you, you don't understand, you can't talk to them in your own language and things like that. So for a long time when I was practicing from 2007 when I came to Bulawayo, that service was not available. We could only do ovulation induction and also open tubes. But in cases where there's a male factor, severe male factor, and you're only seeing 1 or 2 sperms, you say, okay, you have to go to South Africa. So that was the motivation. Now, in terms of what is IVF, IVF basically is what they used to call, or they still call, test tube baby, right? And basically what it involves is after the tests have been done, a woman is given injections for a period of between 8 and 10 days. And the idea is for that woman to produce many eggs. When those eggs are ready, they are monitored during the injection using a scan and some blood tests. When those eggs are ready, she's then taken to a procedure room or a theater, and those eggs are removed from her body to the lab. And then on the day that the eggs are removed, the man will produce a sample. This can come in the form of masturbation, or in some cases where they are not producing a sample, a sperm will be taken from the testes surgically. And then the eggs will then be checked for maturity. The ones that are mature are then fertilized. The ones that fertilized, they then are incubated, that means grown, for a period of between 3 and 5 days. At the end of that period, the woman will then be, obviously the woman will be getting other sort of medication to prepare her home for the coming embryos. The baby, the product is called an embryo.
Okay.
So either on day 5 or day 3, she will then come through, and then the embryo is put from below through the cervix into the womb. If the embryo attaches, that is implants, she'll be pregnant. After 12 days, she has a pregnancy test. If it's positive, it's done again in 48 hours, and if it's okay, she then goes on with the pregnancy. That's
Okay.
what IVF is.
So the going on with the pregnancy is as normal. Does she have any like additional monitoring above that of a woman who conceived naturally, or?
Yeah, well, no, it's not normal, because the drugs that we give knock out the system, and some of the normal support system that happens in natural conception are not existing or not efficient when you've had IVF. So they do get what we call luteal phase support, right? This is basically hormones, and that will be containing either progesterone on its own or progesterone and estrogen. This is to support the lining until the baby's placenta is functioning and is producing its own hormones, which is usually a period of around 12 weeks and thereabout. So for 12 weeks, they'll still be getting either if it's a cream with the inserting down there, or pessaries or injection, they'll be using that for up to 12 weeks.
Okay. So you hear sometimes someone saying, I had multiple cycles of IVF.
Yes.
What would that mean?
Well, the success rate of IVF in any center, even wherever you go, best case scenario, 40%. There are some case centers that claim 50%, but this is to do with patient selection, collect counsel on patients, and things like that. But if you level it out, even in units in the UK, you go down is for below 30%. So it's not 100% and foolproof. So when you're meeting a patient for the first time and you're stimulating them, you don't know how they're going to respond. And whatever strategy that you're using is used based on your past experience and what the evidence that is available in the studies. Some patients will behave exactly the same way as what the studies or other patients have behaved. Some patients will behave differently. So when that happens, you do get, when they behave differently, you do get failure. And the failure can come in different forms. One, you can have failure from just fertilization. Maybe the sperm is not good enough, or the egg is not good enough, and then you don't get fertilization. Or the woman under responds to stimulation drugs, and you don't get enough eggs to fertilize, or the quality of the embryo that comes from there is not good enough, and it won't implant, or the lining is also not good enough, and it won't implant. So there are different stages where you can fail, and then you probably then need a second or a third cycle to then say, okay, we know where the problem was. Can we do it differently here? And then maybe, yeah. But it also depends on the cause. For example, there are some conditions where even when you start, you know, okay, this one might take a little bit longer. And there are some conditions, for example, if it's just a problem with tubes being blocked and everything else is okay, you know that, okay, because we've bypassed the tubes and there's no hydrosalpinx or something, then the success rate is much higher.
And the cycles, you can go for as many as you want,
Yeah,
or how?
they're not harmful.
Okay.
Yeah.
Okay. All right. So IVF is controversial.
Yes.
Religious people are like, there's a whole pro-life, pro-choice. This is supposed to be natural and all these things. What have your perceptions been not here in Zimbabwe particularly to IVF?
I think people are softening to the whole concept. They understand that some of these things that they've been using, like water, oil, and things like that, they are not correct. And also asking your young brother to go in and make your wife pregnant is also not correct. So our population is very literate. They read widely. They know what's going on. Obviously, the only limitation is the funds, but when you explain the concept, they understand it. And okay, fine, my tubes are blocked. So if we can bypass the blockage, whether the baby is made in a lab and It's my baby. It's my genes. Baby is normal. We've had so many babies here. We haven't had an abnormal baby. So they're happy with it. Yeah. Even those religious people, Catholics and whatever, they're coming through and they're accepting it. Because the alternative is just brainwashing people, and some people being mischievous and putting their own sperm and say, okay, you've made her pregnant, which is not correct.
Wow. Okay, there's a school of thought that thinks maybe infertility should be treated naturally.
Yes.
Things like diet or maybe certain exercises or something. What do you think about things like those?
No, it's true. Sometimes when you get a patient, for example, let me talk about a condition called polycystic ovaries. These are basically women that are not ovulating, right? And they do a scan, they find that they've got little cysts, and those cysts are disturbing everything, causing hormonal imbalance, and that woman is going for months and months without periods. If you get that woman to lose 5 to 10% of her weight, the periods will come back, and she can conceive naturally. So the point is, there are conditions that are either worsened or caused by lifestyle. And your natural methods should address that. For example, if you're saying, okay, cut down on your starches and then control your sugar, stop smoking and drinking and things like that, and you correct whatever anomaly that is being caused or worsened by that, it can either cause your condition to disappear, or you get treated naturally like that, or assist you in having a better outcome, even if you're going to have assisted reproduction and treatment. Yeah.
Okay. So you mentioned polycystic ovarian syndrome
Yes.
as something that might be influenced by lifestyle. What other conditions can women get that interfere with infertility that might also be lifestyle dependent?
Well, there are a lot of conditions. I mean, you really have to watch your diet, your weight. You don't want to be too skinny. I mean, that will also cause you to become amenorrheic. That means not go for a period and therefore not produce. And you don't want to be obese. And then, obviously, when it comes to the tubes, like I said, your lifestyle in terms of how you interact with other people, having safe sex, and preventing sexual transmitted infections will preserve your tubes in a healthy state. But if you become exposed to sexual transmitted infections, you lead to damage to your tubes, and that can cause you to have subfertility. I think those are the main ones.
Okay. So you mentioned now we have a wide array of infertility treatments, and before we hadn't. What do you see as the future for the OBGYN, like specialization in the Bulawayo? What else are you looking to do?
For example, I'll talk about our center. Our center right now can compete with any of the centers in South Africa and India. We do have a lot of things. There are just one or two things that we don't offer. I think for the young doctors that we're training now, they're training in at a very good time in terms of being exposed to what we were not exposed to ourselves. Okay. So, and also at an appropriate level. If there are developments, it's much easier for us actually to implement those developments. I think there are just one or two things that we don't have for whatever reason. But the future is bright, and also obviously if the economy does improve and patients are able to afford the services, we'll have less families who are affected by infertility, because IVF has been there since 1978. In other countries, the governments, they fund this treatment. Yeah, people get free cycles. And in other countries, there's medical aids and schemes and things like that that fund treatment. That's what we call third-party finance. And we don't have people having all these problems of not having kids. As you know, especially for women, if a woman doesn't have a child, they are not seen as a woman. They define womanhood to having children.
Being a mother.
Yeah. Motherhood defines womanhood. And the marriages are not good at all. There's lots of problems, violence, infections, including HIV. When someone is trying to get the baby somewhere else and comes back with infections at home, even the society itself doesn't look at those women in good light. It looks at them as if they're still girls, and when there are meetings, they're not even invited, or their opinions are not taken. For themselves, it also affects their confidence, right? When they go to gatherings and everyone is holding their baby and they don't have a baby. So those are the things that we're trying to address in a scientific way. To say, okay, every woman deserves a right to have a baby if they want to. Let it be a choice that, okay, someone says, okay, I can't have a baby, I don't want to, it doesn't matter. And not a limitation of availability of services. Of course, the services are expensive, but we want to give opportunity for women to fulfill their dreams of having a baby and be able to integrate and interact with people. Because if you have a baby through IVF, for example, and you're walking in the street, no one can even tell.
Yeah,
it's only true. Dr. Moyo who knows, okay, how are you? And okay, we assisted there. But in terms of how the baby appears, milestones, the babies are fine. So I think it's important to give that woman that opportunity to have their dream fulfilled.
Okay. So in conclusion, before we go, can you give us maybe 1 or 2 top tips to preserve female infertility? I think the one thing all women know is have your babies early. That's what everyone tells you.
Yeah.
But besides that, do you have any other tips?
Well, look after yourself. Look after yourself in every sense of the word. Look after yourself in terms of your diet. Look after yourself in terms of your body. Don't allow yourself to become too big. And obviously, if you're going to practice intercourse before you start having kids, you have to make sure that it's safe sex and don't get your jobs damaged by someone who's not going to assist you later on. Yeah, obviously it's desirable for women to have their children early, but you know how it is, you guys now, you're into careers and
us so guys.
Yeah. So sometimes it becomes inevitable that you start trying to have a family late, but don't leave it too late. When you get to 35, 36, 37, the chances of being able to conceive, whether you have a problem or not, they reduce quite drastically. Because the simple explanation is that the quality and the quantity of the oocytes that you're now producing is less and less. Because remember, from the time that you started having menstruation, you've been releasing every month. So have your kids early, preferable before 35, because besides the quality in terms of and the quantity, there is an issue to do with genetics of the eggs, right? You then start getting into a zone whereby the eggs that are produced will give you embryos which have genetic abnormalities. Yeah. So look after yourself health-wise and maybe have your kids early.
Okay. All right. Thank you, Dr. Moyo, for that. Thank you for coming. Okay, guys, so you've heard. Let's try have our babies early. I hope you learned something today. See you next time.